Let me know when we're starting. It's hello, everyone. Good morning, good afternoon, and good evening. Welcome to this Evidence to Action webinar. Yes, we can end TB, increasing political leadership and investments on persistent policy gap for children and adolescents. I'm sure this is hopefully is the first of many events you'll be participating in this week as we look at World TB Day on the 24th. For those of you who are familiar with our Evidence to Action webinar series, this one's a little different than our usual one. We really want to dig into some of the policy but political issues as well that are facing TB, particularly in this year where we have a high-level meeting for TB coming up in September. So first, I will go through a few housekeeping notes before we start our discussion today. My name is Catherine Connor. By the way, I'm the Vice President of Policy and Advocacy for the Elizabeth Glaser Pediatric AIDS Foundation and has been active in our sort of childhood TB advocacy work. For today's event, we do have interpretation available. It is available in French, and we're working on Portuguese. So if it's not live yet, we hope it'll be live soon. But to use the interpretation feature, please look for the globe icon at the bottom of the screen and click the language you'd like to hear. Also, we're going to be, please feel free to introduce yourself using the chat feature at the bottom of your screen. We will be using the question and answer feature on this webinar. We have about 20 minutes set up at the end of the session, the moderate discussion for question and answer. So please feel free to use the question and comments section of that. And this is being live streamed and recorded. So this recording will be shared at the end of the webinar. So as I said, today's discussion, next slide, please. Today's discussion is really about talking about sort of the issues facing the landscape around childhood and adolescent TB. We're very lucky to be joined by Dr. Farai Mavhunga from WHO to provide some opening remarks and some scene setting for today's discussion. Then we will have a roundtable discussion for about 15 minutes, for about 25 minutes. That'll be led by these folks. Again, a wide group of people. We have some from government organizations, some civil society, some technical participants. So bringing a lot of diverse perspectives into today's conversation. And then we will have a Q&A session. So I'm purposely moving us a little fast today because I know we only have an hour. So at this moment, I'd like to turn it over to Dr. Farai Mavhunga. Again, Dr. Mavhunga is from the WHO. He leads the Vulnerable Populations, Communities, and Comorbidities Unit of the WHO Global Tuberculosis Program. Dr. Mavhunga is a medical doctor, public health specialist, and is probably one of the best people to walk us through and set the scene for us today. So, Dr. Mavhunga, I'll turn it over to you at this point.
Okay, thank you so much, Catherine. Is it possible to have the slides, please? Okay, sorry, my internet actually went off right at the time that we were supposed to start. So my apologies for that. Okay, I hope you can see me.
Yep.
Okay, great. Thank you so much. And apologies for that. My internet went off right on cue when I was supposed to start. Yes, so as introduced, my name is Farai Mavhunga. I work for the WHO Global Tuberculosis Program. And I'll just be highlighting a few issues to do with TB in children and adolescents. As you know that this week we will have the World TB Day. And the theme is, yes, we can end TB. And probably in many settings, we can actually look at children as a population where we could even go further than other populations as far as ending TB is concerned. If I can have next slide, please. So just some quick highlights from the 2022 Global TB Report. As you probably know already that we had a significant setback as a result of the COVID-19 pandemic with 10.6 million people with TB being estimated in 2021. And this has been an increase compared to the previous years. And this is the first time after many years to see an increase in TB incidence, which was also associated with an increase in TB deaths. But to also highlight that specifically for children and adolescents, we also have a significant burden. So globally, about 11% of all people with TB are estimated to be children between 0 and 14 years old. And similarly, about 209,000 children up to 14 years are estimated to have died in 2021, which is about 13% of all deaths. Unfortunately, the significant majority of children with TB who died as a result of TB, and that's about 80%, were in children less than 5 years. And we do know that the majority of those children, more than 95%, are those who did not access treatment. And we also have a significant number of children who die as a result of both TB and HIV. Next slide, please. So we do know where the gaps are in terms of addressing TB in children as well as in adolescents. And the key gaps are in finding those children with TB. And if we compare the last bar, which is for those who are over 15 years old, we find that in those who are over 15 years old, our estimated treatment coverage is more than 60%, whereas in children less than 5 years old, we have a treatment coverage of just about 30%. So there's a huge case detection gap, especially in children under the age of 5 years. But also we have an opportunity to prevent TB in these children, especially those under 5 years. But unfortunately, over 2/3 of them, of the 1.3 million who were eligible to receive TB preventive treatment, did not receive it in 2021. So again, that's a major gap and an opportunity that we have not been able to optimize up to now. Next slide. And the implication, again, in terms of these targets of us failing to find a significant proportion of children with TB, it is being reflected in our progress or limited progress towards attaining the UN HLM targets. As you can see for children, against a target of 3.5 million up to 2022, from 2018, we had managed to find 1.9 million, which is about 54%, which in effect, it's unlikely that in the remaining year, we'll be able to achieve this target. And that is also translated or reflected even more so in the children to be treated for drug-resistant TB, where in the 4 years up to 2021, we had only managed to find and treat 15% of the estimated children with drug-resistant TB. Next slide. Next. Yes, so again, similarly, just to re-highlight the targets for TB preventive treatment, again, it's a missed opportunity when we are talking especially about children who are less than 5 years old. So although there is some progress, I think we are still significantly behind the targets of finding children who have been exposed to TB or under 5 years old who could benefit from TB preventive treatment. Next slide. So WHO has been also trying to contribute to these efforts to find and treat children with TB, and we recently released the WHO guidelines and operational handbook on TB in children and adolescents. And this addresses key aspects of diagnosis and treatment and care along the continuum of care. These guidelines are available on the TB knowledge sharing platform, and they were launched last year during World TB Day. Next. So having launched these guidelines, the focus now shifts to operationalizing them and to supporting countries to implement the recommendations included in these guidelines. And this is being done through various mechanisms. And I think various partners on this call have been involved in one way or another in supporting these efforts. So there are several program reviews that countries have been involved in. Countries have also been involved in updating national strategic plans, and we do have the guidance for national strategic planning for tuberculosis, which we also launched last year, which incorporates elements of TB in vulnerable populations, and also more specifically using the example of children and adolescents on how to address TB in these populations. And we're also in the process of developing e-courses to facilitate capacity building. And we have two e-courses that are being developed. One, a programmatic e-course, which is really looking at the programmatic aspects, but one also a course that can be customized to train health workers at primary healthcare level. And as you know, we are also updating the roadmap towards ending TB in children and adolescents to be published this year at the annual meeting of the working group on TB in children and adolescents. And we also have a planned follow-up or the second meeting on pediatric anti-TB drug optimization priority list, which will take place also later this year. Next slide. Next. Okay, thank you so much. So I think, again, this is just to highlight some of the key and major developments, at least from the WHO side, as far as addressing TB in children and adolescents. And I would like to acknowledge, I'm actually speaking here on behalf of my director, Dr. Teresa Kasaeva, who is the director of the WHO Global TB Program, but also to acknowledge my colleagues who have been involved and who are leading this work on TB in children and adolescents. And Annemieke is here with me, also to thank her a lot for putting together these few slides to set the scene. Otherwise, thank you so much. I look forward to the fruitful deliberations and discussions during this session. Thank you, and back to you, Kathy.
Thank you so much, Dr. Mavhunga. I think you did an excellent job in highlighting some of the major challenges that we face in addressing childhood and adolescent TB issues. You know, I'm often asked through our advocacy work why the Pediatric AIDS Foundation is so focused on TB and childhood TB. And I think a lot of the details that you presented really highlight why, is that not only is there the issue of HIV TB co-infection in children, but also many of the issues we see when we're dealing with pediatric HIV, we see in childhood TB, such as issues around finding the children, getting them access on treatment, the high mortality when you miss those opportunities to link them to treatment, but also that focus on prevention. I think you really presented nicely, is that if there were more opportunities and really closing those gaps in prevention could change the landscape altogether. I just also want to note, thank you for highlighting the tools that have been put together by WHO and the partners, because I think many of those things, as you said, have been developed by those on this call, but I think are being used in the field and are being updated as people use them and we learn more about what can be done and what innovations need to be incorporated. So I know you may have to leave us, but I hope you can stay around a little while and hear some of the discussion. So I'd like to move into the moderated discussion, if that's okay. You know, again, we have a great panel today representing all corners of the childhood TB landscape here. So if we're ready to kick it off. I'm going to introduce each panelist when I ask them a question, so I don't have to bore you with CVs and resumes at the outset. And I've encouraged participants to interrupt if they feel compelled to say something, but we are going to move along to make sure we have time for the audience to ask questions and answers as well. So I would like to kick off with Dr. Sahu, if I might, who is joining us from a very far away time zone. He's the Deputy Executive Director of the Stop TB Partnership. He's also a medical doctor, a public health specialist for over 20 years, but is also a very passionate advocate for TB innovation and equitable access. So I think a great first panelist to talk. So Dr. Sahu, the Stop TB Partnership is known worldwide for its advocacy and its political leadership for TB. Why do you think political will to fight TB has been so difficult sometimes to muster, considering that TB is one of the oldest and leading infectious killers in the world? Where do you see positive signs of increased political support, particularly around childhood TB?
Thank you, Catherine. Greetings from the Stop TB Partnership, and it's a pleasure to be here. Let me address your question, Catherine. We all know that TB disproportionately affects poor people in poor countries. Rich countries have brought down the rates of TB and don't perceive the fear and urgency as we had seen during the last 2 years of COVID pandemic. In high TB burden countries, the richer and more powerful people are less affected by TB. So it is not by default that we should expect that leaders and decision makers in high TB burden countries will lead, act, or invest on TB. We need to highlight TB, and within that context, childhood and adolescent TB to our leaders in TB high burden countries. We also need to highlight TB as an important child health issue to people who are working on child health, so that TB is not left behind in the child health priorities. All partners and national TB responses need to ensure that the leaders of countries are engaged in the response against TB. We need to ensure that for increased political commitment, we communicate in simple ways, and make them understand what is the problem, what is the solution, why the leaders should be involved and engaged, and what is their role. This is exactly what for the last few years we at Stop TB Partnership have been trying to do along with partners. We are reaching out to leaders, ministers of health, but also beyond ministers of health to heads of state and heads of governments now. At the international level, this resulted in adding New York, and the UN General Assembly in New York to the map of TB. It wasn't there before. For the first time, political leadership of countries beyond health ministers discussed TB in 2018 UN high-level meeting. And now we have the second UN high-level meeting scheduled on 22nd of September this year in New York in the UN General Assembly. At country level, we have already a few heads of states who are taking the leadership in their countries. For example, India, Indonesia, Nigeria, and a few others. On 24th March this year, that means 4 days from now, His Excellency, the Prime Minister of India, will be speaking at an event in Varanasi in India. We also know that some of the other heads of states are engaging more into their TB responses. We plan to launch a coalition of leaders soon, and you will hear about it after our board meeting, which is also happening in Varanasi at the weekend, at this just after the World TB Day. TB has been also discussed under the G20 India and Indonesia presidency last year and this year. And we also look forward to discussing TB right at the G7 meeting, the presidency of Japan. So yes, political commitment for TB and childhood TB is important. It is growing. The 2018 UNHLM was a turning point, and 2023 is a huge opportunity that we all as partners should take. On the World TB Day, in line with the theme set by the Stop TB Partnership for this year, let me say, yes, we can end TB in children and adolescents, and that too earlier than other age groups. I would stop here. Thank you.
No, thank you, Dr. Sahu. I think your points are really well taken on the equity issues around poverty, but also I think it's interesting when you don't think about it, how much there has been this sort of shift in leadership, moving away from just ministries, high level leaders beginning to be involved. And it kind of tees up really nicely in my next question for Ms. Whitney Mavhunga. She's the Health Policy and Communications Advocacy Specialist for the African Union Commission. And part of that work includes working with heads of states on the agenda, the continental agenda, to end TB in Africa by 2030. And so, again, for you, Ms. Mavhunga, the recent call to action on childhood TB led by the African Union and WHO was a significant sign that childhood TB is becoming a higher priority issue in Africa. Can you speak to the significance of regional political commitments, given and what you see as the next steps that the African Union can take as being responsible for policy development, but also the implementation of policies that reach across the continent?
Thank you, Catherine, and greetings to everyone from a very rainy Addis Ababa. As the previous speakers have rightly mentioned, that there is hope to end TB by 2030, and indeed, this move was a significant placement of the interest and the intention to, end TB and have it prioritized among the minds and the agenda of our political leaders. So for those who are not able to join us during this very important event, some of the issues that went into this call to action is ensuring that we have meaningful investment in tools that can advance, how we respond to TB in the African countries and beyond, prioritization of funding and having regular exchanges between member states and other partners who are working in the field. I'm very impressed to hear about the advancements that are happening from the WHO and work to build the capacity of community health workers, preparing operation guidelines on how we can bring our work together. So how can this call to action really sit into what we are already doing, and how can we collaborate to ensure that the call to action is not just a commitment, yet another commitment that sits on our shelves, but it turns into action, that member states and everyone at the household level can feel the impact. So as we understand, TB is a social and economic issue. And we know in Africa, especially at the AU level, we will try as much as we can to have conversation on diseases and TB. But at the end of the day, different countries have priorities based on the agendas that are taking place in their countries. And ladies and gentlemen, if the leaders don't understand that ending TB or addressing disease prevalence is not a priority, and we don't stand a chance of having funding allocated, time allocated, all that. So the best way forward, as I see, or built on the experience that we have the AU, is making sure that we are engaged with the political leaders at every level, whatever opportunity that someone has rightfully mentioned that are coming up, and how can we see that we are tabling the matters that affect TB, quickly has already been talked about, and how can we take advantage of the convener role of the EU Commission to ensure that this, the call to action and other TB-related continental policies, the EU Health Strategy, the legal framework and TB and malaria, the Africa Union, how do we bring all this together in one simple package, model of communication or policy dialogue can easily be digested with the member states. And this webinar is taking place of a very important week. World TB Day is coming up towards the end of the week. At the EU Commission level, we'll be having our commemoration with the Ministry of Health in Gambia. And one of the things that will be taking place is they will take us around TB facilities and centers to show us what is happening at the country. And on our part, we'll be bringing different partners to be a part of this conversation, because the EU convenes, yes, we develop policy, but we have partners who provide funding. We have others who specialize on innovation, bringing all the voices together, hear directly from the member states on what they need to make these policies a reality, and then the conversation from there. So I believe that's a good start, convening and then having establishing impactful partnerships and having productive conversations. Thank you.
Thank you, Whitney. I think that really what jumped out is that this is a long-term conversation, right? The call to action is sort of the beginning, but it sounds like you're already talking about, you know, how to prioritize funding, how to bring sort of innovation into the conversation with these countries. And we're really excited to hear how the event in the Gambia goes, bringing some real tangibility to issues that aren't always tangible to some of these leaders. Oftentimes things get hidden, right? We have these global targets, these regional targets, but everyone needs to understand their country context. I think that's great what you're leading on there. And actually the discussion on innovation leads nicely to Annemieke Brands, also from WHO, working with Dr. Farai. Annemieke is the technical officer in the same office, the vulnerable populations, communities, and comorbidities unit of the WHO TB program. But many of you probably know her most because she leads the actual working group, the Child and Adolescent Working Group on TB. So very much on the front lines of these discussions every day. So Ms. Brands, like in many areas of global health, you know, child-specific medications and child-friendly tools are really needed to provide quality care and to see those outcomes that even Dr. Sahu discussed. What tools do you think are available right now that could fight childhood TB that have not been widely adopted by donors or country programs? And conversely, like what TB medicines and formulations has WHO identified as needing to be developed for children and for what age groups?
Thank you so much, Catherine. And first of all, thank you to EGPAF for organizing this wonderful webinar. It's an exciting time to address these persistent policy practice gaps. And in terms of new tools, we have some new tools both for TB treatment, but also for diagnosis. And among the new tools for treatment of infection and disease are, first of all, shorter TB preventive regimens, including 3HR, 3HP, and 1HP, should the child be above 2 years and able to swallow pills. Then we have shorter regimens to treat drug-susceptible TB, including a 4-month regimen of 2 months of isoniazid, rifampicin, pyrazidamide with or without ethambutol, followed by 2 months of isoniazid and rifampicin for children between 3 months and 16 years of age with non-severe TB, and an alternative regimen of 4 months composed of isoniazid, rifapentin, moxifloxacin, and pyrazidamide for adolescents 12 years and older. In addition, to treat multi-drug and rifampicin-resistant TB, bedaquiline may now be used as part of shorter and longer regimens, and delamanid as part of longer individualized regimens in children of all ages. And these 2 recommendations now make it possible to design all oral regimens for everyone. Then also, I would like to mention that for children and adolescents with drug-susceptible TB meningitis, they can now be treated with a 6-month intensive regimen consisting of isoniazid, rifampicin, pyrazidamide, and ethionamide. And this regimen may be used as an alternative to the standard 12-month regimen. And as we know, shorter regimens favor adherence and treatment completion. But as Farai mentioned earlier, and you hinted at earlier, countries should first find the children and adolescents with TB or at risk of TB. And the majority of children and adolescents seek care at the primary healthcare level. And therefore, TB services need to be decentralized and integrated at lower levels of the healthcare system, in addition to more specialized services at higher levels of care. TB screening should be conducted in health facilities, including in outpatient settings, nutrition, HIV, and other relevant child health clinics, like the Unit 8 funded CAP TB project implemented by EGPAF has shown so well. And it's also important to scale up community-based contact investigation approaches linked to diagnostic evaluation and access to TB preventive treatment. And then there are some new tools to facilitate diagnosis, including the use of alternative, less invasive specimens for expert MTB-RIF and ultra testing. And most of all, I want to mention the stool, the use of stool, and implementation of evidence-based treatment decision algorithms, which include rapid molecular test and chest radiography where available, but also allow for clinical diagnosis where bacteriological confirmation cannot be done or is negative. And to roll out these new tools and approaches, countries are encouraged to update their national TB guidelines, update their national strategic plans, include these interventions into funding requests. And here I would like to refer to a checklist that was developed by EGPAF together with the Child and Adolescent TB Working Group. And countries need to build a capacity through training and supportive supervision, procure child-friendly formulations, and create demand for them. And effective communities and civil society organizations can definitely support these processes. And then with respect to your last question on TB medicines and formulations that WHO has identified as needing to be developed for children, I'd first like to mention that child-friendly formulations of all first and second line drugs are now available through the Stop TB Partnership Global Drug Facility. However, having enough suppliers would certainly contribute to sustainability and may also bring down the price. And WHO convenes a pediatric TB drug optimization meeting to provide advice on which priority formulations need to be developed. And a single functionally scored dispersible rifampicin formulation was identified as a priority to allow for multiple uses for prevention and treatment in the future. So 3 HP, 1 HP, and perhaps first line treatment in the future. Let me stop here.
Thanks, Annemieke. I think it's really interesting you raised the point that it's not enough to have the tools. You need the supply chain around the tools. So the suppliers to make sure you have enough supply, but also price reduction, which I know is at the heart, a passion issue for one of our speakers, price reduction. But I think it's also interesting how you link the fact, again, that the tools, there's stuff you have to do around those tools. So the trainings, and sort of the integration of service delivery in countries. So I'd like to bring in EGPAF's country regional director now, Dr. John Dedicamina, he has experience in Cameroon, DRC, but really understands the ins and outs of sort of how these things work on the ground. So I want to ask you, John, we heard in the presentations about children who have TB infection or at risk of TB infection, but haven't been identified. From your experience, what are your recommendations for finding the missing children in the TB surveillance? And what are some best practices for supporting contact investigation programs?
Thanks, Catherine, for this opportunity offered to me to share my experience, but also learn from other colleagues. And I just wanted to thank my previous colleague and panelists for great intervention and feedback. So this is a very good question, Catherine, and I would like to articulate my response around 3 to 4 group of causes, and then provide some specific recommendations. So the first group of why we are missing those children, the first group of causes is related to general weakness in the health system. And you remember that Dr. Mavhunga discussed about the impact of COVID-19 on the TB in general. And I had the chance to have a look at on the WHO TB Global Report 2022, And I was surprised to see that the number of diagnosed cases decreased from 7.1 million to in 2019 to 5.8 million in 2021, which is a significant decrease in terms of identification. And this is actually, what can I say, very, very important in children with all the disparities that we can talk. So for this first group of causes, I think I would recommend actually to increase the access for diagnosis and treatment. And thank Brian for additional input on that. And I fully agree for that, because in most of the countries, we need to actually make accessible the diagnosis, but also treatment in terms of financial access, eliminate, for instance, all the user fees. I remember in Cameroon, I've been really pushing to eliminate the user fees, and we succeed actually with PEPFAR, support from PEPFAR to eliminate that. But also geographic access in terms of most of treatment and diagnosis facilities are located far from some population. The second group of causes is related to health workforce. Actually, most of the time, I realize that most of the providers are limited and have less qualified skills when it comes to take care of pediatric TB and pediatric in general. And even they have some limitation in terms of applying or being compliant with the algorithm and standard that have been proposed either by the country, first of all by WHO, and adapted by the country team. SOP exists. We have standards, we have some good algorithms, but are not implemented by providers. So we are recommending here to reinforce the capacity in terms of improving, for instance, the quality improvement, the CQI initiative, but also sustainable support and mentorship, training, to make sure that those health providers can provide a screening at the community, but also at the facility level. Because most of the time, we miss most of the children. Those are coming at the facility are not really screened for TB, and even in the community, there are not activities that are targeting those children. The third group of causes is limitation in adequate lab equipment. And here I can talk of, that we can use the verbal screening, but also we can use the chest X-ray for in these cases. But those equipment are not really available in most of settings, mostly in the sub-Saharan Africa. I'm supporting the Western and Central Africa region for EGPAF, and I know what that means in terms of availability of chest X-ray machines in different areas. But not only this, but also we have the issue of gene expert. I like what Brian said, because this is a very important tool that can increase even the yield in terms of pediatric, to help us to identify more children or pediatric patients by using ultra cartridge. But for instance, this morning I have been discussing with the director of National TB Control Program for DRC, who told me that they had just 155 gene experts in the entire country, whereas the number of facilities that are supposed to taking care of TB patient and diagnosis are more than 2,000. So availability is an issue, and even the cartridge, who is going to provide that? This is a big issue for. So for that, I think it's very important to increase the availability of those tools, which are very important tools to identify patients in terms of screening and diagnosis, but also increase the coverage for gene expert, because this is very important. In DRC, for instance, they are doing a kind of pilot study to use tools with the gene expert, with the ultra cartridge to identify TB cases in children, which is not only children, but also people living with HIV/AIDS, which is very, very important tool. So we need more. And lastly, I can add also some specific recommendation related to research. For instance, I like what Brian said, to find the new tools of effective diagnosis, but find also new drugs. And I'm happy to hear that. But also put emphasis the focus on also effective vaccine. This could be something we can think of also for the future. So let me stop there, and over to you.
Thanks, John. I appreciate that everything is in your bucket list. Vaccine, screening, labs, better tools. But it is kind of shocking that a disease that's been around for thousands of years, we're still sort of at this place where we don't feel like we have the right tools that are effective or make this easy to do in country. And I think your point about screening in particular, and even the X-ray technology and the gene expert availability really hit home to me. I'm going to turn to Lindsay now. And then after Lindsay, I'm going to open it up. We had many other questions ready for the group, but this discussion's been so great. So please do put your Q&As in the link there. So Lindsay McKenna, again, known to a lot of you in the TB world, is at Treatment Action Group, or TAG, co-director of the TB project, but really known for her work with community, particularly the CABs, the community advisory boards, on sort of pushing for this sort of improvement, development of these tools in country. And if you've ever read the pipeline reports, you can send her a thank you in the notes as well. So Lindsay, I feel like you're kind of a great sort of last questioner on this, because, you know, your organization right now is leading the 146x24 campaign that aims to close some of these gaps between shorter, safer, and effective TB treatments that exist and what actual regimens are being implemented, right? So I think this kind of ties together what Dr. John and Annemieke were saying, that there's stuff out there, but how is it getting where it's going? And this includes the 4-month TB treatment regimen for children. Can you speak about that campaign for a minute, and also about how it challenges governments, funders, and global health actors to do more?
Yeah, thanks so much, Catherine. So the 146x24 campaign, just to give you folks who are less familiar with it a little bit of background about where the name comes from. The 1, the 4, and the 6 each stand for one of the shorter regimens that Annemieke and others have spoken to today. The 1 stands for 1 month or once weekly TB preventive treatment regimens. The 4 stands for the 4-month drug-sensitive TB treatment regimens, and the 6 stands for the 6-month shorter all-oral treatment regimens for drug-resistant TB. And the by 24 gives us a deadline by the end of 2024, which is when we want everyone everywhere to have access to these short course regimens as a human right. And so when we launched this campaign, it came at a critical moment when we realized that after 20 plus years of advocacy and investments in research and development, we finally had shorter course regimens that were safer and more effective across the board, from prevention all the way through to drug-resistant TB. And these regimens are backed up by really rigorous randomized controlled clinical trials. We have WHO recommendations for all of these shorter regimens. And yet globally, when we looked around, very few people affected by TB had access to these shorter regimens. And so that at first, inspired a little bit of outrage, but then it gave us kind of an idea to launch this campaign that we feel it's kind of like TB's 3x5 moment. For those of you who are familiar with the 3x5 campaign in HIV, it was launched right when there were effective HIV treatments available in the US, but not globally, in other countries where there were high burdens of HIV. And it was really a moment where people coalesced and rallied around these HIV regimens and demanded that they be available, and took action and put funding in place to make them available globally. And so we feel it's kind of TB's 3x5 moment. And these regimens give us an opportunity and something to coalesce around to rally the political will, the funding, and the energy we need to end TB. And so, the campaign speaks primarily to governments, as Catherine mentioned. It calls on governments to take action to put in place what Dr. Paul Farmer called the 5 S's. The staff, the stuff, the space, the systems, and the support. These are the things that John and others have mentioned kind of need to come in place around new tools. You can't just drop kind of a biomedical intervention into a program. You need these other elements in place to make sure people who need them actually have access to them. And so it calls on governments to take action in terms of updating their guidelines, putting these shorter regimens and new interventions and those 5 S's in national strategic plans and in funding proposals, and allocating the budget needed for these interventions to ultimately be successful. But it also speaks to other actors and duty bearers, including researchers, to make sure that we are filling research gaps that stand between people and affected communities who need these interventions and access to them. It calls on donors to really step up and fill some of these funding gaps to supplement what countries are allocating to TB and health budgets. And really, it calls on everyone. Everybody has a role to play. And finally, it speaks to, I think, pharmaceutical and diagnostics companies and calls on them to help us remove some of the barriers that stand between people and access to these interventions. So it calls for, pharmaceutical companies to develop fit-for-purpose formulations, FDCs to support the new 4-month regimen that has rifapentine and moxifloxacin in it, a pediatric formulation of rifapentine. It calls on manufacturers to develop what we need here, and also on companies like Cepheid and other diagnostics manufacturers to help bring down the prices of these molecular tests that we really need to scale up in order to get people into care and access to these shorter regimens. And so with the 146x24 campaign, really everybody has a role to play. And we think it's a really compelling kind of platform to mobilize around to try to rally the really massive political will and funding and energy that we're going to need to end TB by 2030. I'll stop there. Thanks so much.
No, thanks, Lindsay. And then I'll ask my colleague who's running the chat to make sure there's a link to the 146x24 campaign. I think for those who haven't taken a look at it, I do think, not only the real depth of the recommendations, a lot of times these campaigns rely on a slogan to do the heavy work. And I think what they've put together, TAG, really digs into which actor can really help on which part of the problem. And so recommend that people take a look at that and see how they can get involved. I'm looking at the clock. I'm also looking at Q&A. So I'm going to take my liberty as moderator and ask one more question before turning to the Q&A. And I'm going to just put it to everybody, because I think what Lindsay said, I feel like the last 3 or 4 speakers have really mentioned investment, and it's in the title of this webinar, but we haven't really talked about it. And so I just want to kind of turn a general question over, as I think we've seen a lot of, from hearing from Dr. Sahu, from hearing from Ms. Mavhunga, like we're hearing this political leadership, we see this HLM coming, so we know how to start driving political leadership. What do we think we need to do on financial investment? From donor governments, from others, is there anything that you speakers want to go out on a limb and say, how can we drive more financial investment to go with that political leadership? So I'm going to open up to everybody, and then I'm going to turn to the Q&A. And if you want to be shy, I won't harass anybody except Dr. Sahu, because I know Stop TB definitely has opinions on the financial side of this.
Maybe I can start off.
Okay.
Yes, so as we all know, there were some commitments made in the UNHLM 2018 on financing to be made available for TB. But what we see now is out of the $13 billion per annum to be made available, we have about $5 to $6 billion per year. This is for the implementation of care and prevention activities. There was another commitment of funding research and development of new tools. That was $2 billion per annum. And just last year, we reached $1 billion per annum. It was below 1 billion the previous years. So first time it reached 1 billion last year, but still far short of what it should be. Going forward, the gap has further increased. Why? Because we now have a plan, a global plan that was developed by Stop TB Partnership in a very inclusive way from 2023 to 2030. Because of the setback due to COVID and the lack of progress in the previous years, now the cost the price tag has gone up. So now we will require 4 times, at least 4 times, 4 to 5 times of the currently available money if we have to end TB by 2030. But let me tell you that while the traditional sources of funding remain almost similar, especially the external funding through Global Fund and very few other bilateral donors, there are other mechanisms of funding which have shown some positive results recently. For example, there is something called blended financing, blending of loans with grants, which is done usually World Bank loan and Global Fund financing to buy down the loan. That is a methodology that was that worked out first time with India, but just last month, or maybe it was announced last month, but maybe it was done towards the end of last year and beginning of this year. Indonesia received a big amount of money in this blended financing. We also have Global Fund, who has informed to their board that in the C19 RM, which is beyond the TB, HIV, malaria funding, this was for COVID-19, TB has received 133 million. So these are additional money, not the TB allocation money. We also know that there are many other opportunities are coming up. So I would call definitely for a strong action to see that TB is included in UHC funding. Remember, there is also a UHC high-level meeting happening. TB should be part of child health funding without achieving things on TB, on childhood TB. We cannot have child health in high TB burden countries. We cannot have UHC. And also, very importantly, for the pandemic preparedness, as you all may have seen, pandemic fund of the bank has asked for a call to countries. TB can be strongly linked to pandemic. And just if you allow me 2 minutes to say on something that was already said, diagnostics was a big gain during the C19 RM of Global Fund. And this is something that we should also call for the pandemic fund to invest. Any kind of molecular diagnostic for future will help, and it will have dual purpose of TB as well as future pandemic. X-rays, we talked about X-rays, molecular technology. Also, we should not just talk about expert in 2023. We have TrueNat, more molecular tests coming up. So that's one area. The second area is in pandemic preparedness, contact investigation. Whatever pandemics you have in future, whatever infections airborne, you need a contact investigation system. Children get TB not by themselves going out and getting it. Most often it is being a contact, vulnerable contact of somebody in the household. We do not have currently system to reach out to children in the household. They will not come. Healthy children are unlikely to be in the health system. So that health workforce should be tailored in such a way that you have community actors there going out to do the contact investigation. So I would stop there just to give others a chance also.
Well, sadly, I'm not going to give others a chance just because I'm looking at the clock and we promised people 1 hour. We have one question in the Q&A and then I will kind of close up and maybe ask a more provocative question. The question we got is about sort of HIV TB, which I know some people have, on the screen may not have worked out, but it says, despite the fact that each policy is context dependent, which do you think is the most effective for eliminating TB amongst people living with HIV? Also, it says, do you think in addition to TB screening, INH prophylaxis to negative screen patients is efficient? If yes, what are the criteria? So that one's a bit complicated, but I'll let people, I think the first one may be easier, and I see that Dr. Sahu's typing the answer too, but I don't know if anyone wants to just make a comment about sort of the most effective tool for eliminating TB amongst people living with HIV. I'll look for any speakers here on the screen. Lindsay?
Yeah, I was just going to say, I think one of the most important things is really screening and testing for TB among people living with HIV. I think what we see is that there's a big gap there, which is why TB is a leading cause of death among people living with HIV. And interestingly, we actually have a true point of care test very specific to people living with HIV who have advanced disease or a low CD4 count, called the TB LAM test. It's a urine-based test. It actually works best in these populations who are really sick, and which otherwise are really hard to diagnose with TB using more conventional methods. And so I think one of the biggest areas of focus for addressing TB among people living with HIV is to really start doing a better job screening and testing. And then to the second part of your question, making sure that among people living with HIV who have had a recent exposure to TB or are at high risk of TB, making sure that they get access to TB preventive treatment, and with these shorter regimens that we now have available that are more tolerable and effective at preventing TB disease.
John?
Yes, Catherine, I just wanted to say that I second Landry on that, because we know what works. We know for among people living with HIV, which is important, the evidence exists, but also the tools we have, screening, those who are screening need to be taken into care, but also providing TPT for those who are eligible for that initiative, but also make sure that they can actually be on TPT until they complete the treatment for that. So this is actually very important. So it's known, the tools exist in most of the countries. Sometimes we may have the compliance with what are the standards and the policy existing in different countries. And we need to hold the country teams, country program accountable for that. Over.
Thanks, John. Anyone else?
Maybe
Right.
can I make one
Yeah.
more?
No, that's I look. Everyone jump in. Yeah, absolutely.
One more addition to John's excellent point is that sometimes with TB interventions that are targeted to people living with HIV, they fall between the cracks of the TB program versus the HIV program. And there's kind of dispersion of accountability. And so I think that we need to acknowledge that TB and HIV are kind of a shared responsibility by both programs, and that each has a role to play in the other. And that way, we don't have these tools that are really effective like TB LAM that ultimately are available but not accessible because they're not being implemented by one program because the other feels it's the other program's responsibility. So I just wanted to.
I think that's an excellent point. It kind of goes into a little bit of Dr. Sahu was saying in the question about funding. What I took away from that was, we're not just talking about integrated service delivery, we're talking about integrated technologies and integrated funding streams. I think to your point, joint responsibility. So I think we're really turning a corner where even in the pandemic preparedness, the way these nexi kind of exist have to be better acknowledged and structured around. And so I just want to thank you all. I'm going to leave you with one big question, but I want to say, if I was just from this conversation, the kind of two big takeaways I have is that, every single one of you mentioned sort of the idea of equity and the idea of social and economic issues. And I think that is something that a lot of times in these more clinical, we're talking about different regimens and shorter course, and we forget that there are those barriers there. And I think it's an excellent point that each one of you made. And then secondly, it's just a really exciting time in TB. I mean, we've seen growing political leadership, even though the funding's not where we want to be, as Dr. Sahu said, we are seeing increases. The innovations, the fact that these things are available. And again, if a stool-based testing technology doesn't get you excited, this is probably not your webinar. There are those of us who've been waiting for a non-sputum based test, particularly for children, for a really long time. So, there are things to look forward to and to get excited about. And so in that sort of vein of excitement going into the week of World TB Day, the final question for all of you is sort of with the UN with the UN high level meeting happening in September, if there was one pledge or one commitment you'd like to see the member states make, what would it be? And that's how we're going to close out. So I'm going to let you volunteer your answers as opposed to calling on you. So Annemieke, I see you're off mute.
Thank you so much. It's hard to choose, but I would say bringing services closer to where children, adolescents, and families live, because this has the potential to avoid unnecessarily delays unnecessary hospitalization, suffering, and death, reduce the cost, and improve post-TB health. And it also will facilitate that children and adolescents remain in education. Thank you.
All right, bringing service delivery closer to kids. Whitney.
That does actually lead into my position to have an African-led continental advocacy campaign. I know that we've got one now, which is exciting because we do have several for HIV and one big one for malaria at AU level. How can we borrow from the experience we've had on these campaigns and translate that to HIV? Of course, we do want, yes, to have joint responsibility, but we have to remember we are developing policies that will be implemented by real people. So how do we have the real conversations about what is affecting them in a way that is going to build that sense of ownership at the level and trickle up now to the policy level? So that's what I would table for consideration.
Thank you. I think the country level dialogue and that African leadership, African-led campaign sounds really exciting to me. All right, who's left? I got Dr. Sahu, Lindsay, and John. Lindsay.
Yeah, I'll go next. Maybe mine is more obvious, but I want to see leaders commit to 146 by 24. Having that in place, and then also just to say a second commitment, if I'm allowed, is to make sure that there's a commitment to really investing in TB research and development, because we still have unmet needs. Someone earlier mentioned the need for a TB vaccine, and that'll really be the game changer. And so 146 by 24 and investments in TB R&D, especially towards a new TB vaccine.
Thanks, Lindsay. All right, Dr. John, you're next.
So in short, I can say domestic contribution to the budget, health budget, and specifically for TB, that would be really important. And specifically case identification in TB, we should be taking that as a commitment that we should expect the head of state or the representative from country to take that during that high level meeting. Yeah.
Thanks, John. And actually, Whitney, that connects to yours a little bit, the specific TB budget lines and domestic budgets, I think, and a specific budget line for children in those domestic budgets, really helps a lot. All right, Dr. Sahu, you get the last wish for the UN high-level meeting.
I'll be short. I would like to see a people-centered, a truly people-centered commitment there, not health-centered, centered or health services centered, but people-centered, commitments there, both in TB care and prevention, and also in the research side. Thank you.
Thank you. And thank you, everybody, for joining. Again, this is a little different for EGPAF, doing one on political leadership and the financial investment, but I think we had a really rich dialogue today, touched on many technical and non-technical issues. The African leadership discussion, I think, was really great. And Dr. Sahu and everybody else, thank you so much today. Again, I just want to remind people this has been recorded, so we will be sending out the recorder afterwards. And enjoy your week of TB, I don't know if celebrations, recognition, the week of TB recognition that's coming everyone's way. Thank you so much. I hope you join our next E-Day.
Thank you.
Thank you.
Bye.